Good evening. Good evening. My name is Joel Bauer, and I'm the Director of Education for IBD for Lifebulb. Today we have two panelists. One is a radiologist, Dr. Burton Cohen, and the other is a gastroenterologist, Dr. Peter Rubin. Both of them are associate professors at Mount Sinai Hospital and are very active in IBD. Before we get into the questions and so on, I want to say that some people will come and get referred to a gastroenterologist by their internist, and some of the workup might have been done by the internist. For example, if someone presents with diarrhea, the first thing may not be an endoscopy. It may be things including cultures and so on and so forth. But once it gets to the point where the internist or the patient suspects that the patient has IBD, they would probably send the patient to Dr. Rubin. And then he will proceed to question the patient, find out what medications they're on, find out their history, and then he may want radiologic help, or he may need endoscopic help. So we can proceed from there. Karin, did you want to say anything?
Sure. Thank you so much, Joel, and thank you so much to everyone who is dialing in to listen to us today. We're really excited about launching this seminar series, which will comprise of a number of episodes talking about the journey with inflammatory bowel disease, and today, of course, opening with the very first diagnosis. And we're honored to have three thought leaders here today, and being co-moderating with Dr. Bauer is my honor. So from the Lifebulb perspective, I'm the CEO of Lifebulb. We welcome questions as we speak. We have some pre-submitted questions that we will go through. But again, anyone out there who wants to ask these three doctors questions, please just submit them. And as always, this is recorded and archived, so you can watch it again in the future, and also will be written down as an article. So go ahead, please, Dr. Bauer.
Well, I'll ask the first question. So, Peter, let us say that a family practitioner or a primary care physician sends you a patient who has had, a 30-year-old patient who has had diarrhea with bleeding for about 6 months. And he's tried various things like low modal or something like that. What do you do when you see that patient?
Well, things need to be done in a certain rational order. And so you start off by talking to the patient and reviewing all of the records of what's already been done. Because you don't want to repeat the things that are recent and have already happened, and you have to talk to the patient. It needs to be a dialogue. There's a whole series of questions. This is very much like solving a mystery, like Sherlock Holmes, and you have to ask a whole number of questions of the patient to really understand when the symptoms started, how long they've been going on, what seems to provoke them, what seems to help them, what have they tried, what tests have they had done? And so there's a whole interrogation that has to go on. And then there ought to be a physical examination, because there are many, many things on the physical exam that will supplement what you've learned in the history to help you along in your thinking. And then there need to be certain tests. As you mentioned, some of them may have already been done, and you don't need to repeat those, but often there are other key tests that have not been done, especially when it comes to Crohn's and ulcerative colitis. There are some tests that are not routinely done, and you may need to do those tests in order to find out what the diagnosis is. The test may be a blood test, and it may be sending a patient for a radiologic or an X-ray kind of test, or it may be an endoscopy, it may be a stool culture, depending on what the story is. Everybody is different. And
so let's say Peter,
individualize.
Let's say, Peter, a 30-year-old person has had 2 months of bloody diarrhea, and she's lost 10 pounds. And she's had no blood tests, no stool culture, she's had nothing. So what are the first things that you do?
Then you're starting from scratch. And
that's okay.
You're starting for nothing's been done. That makes it easier in a way, because there's a whole panel of tests that you would want to have done. You would want to certainly have stool cultures, and there's some key questions in the history And before you even do any tests, you want to know, was this person started recently on any new medication? Has this person been traveling? Has this person really recently taken a course of antibiotics? All of those can be crucial in making the diagnosis.
So Dr. Rubin, just if I may intervene, you are an expert in inflammatory bowel disease. A gastroenterologist is one of the premier hospitals, together also with Dr. Cohen. So for most patients, they are probably not situated in New York City. What kind of signs and symptoms, what should patients be thinking about, looking for when suspecting that this is not just a traveler's diarrhea or you know, a food poisoning? What should they be looking for when they're sitting somewhere in the country, out in the country, with no specialist available?
Okay, that's a great question, Karen. I think that part of it is how long it's been going on.
Mm-hmm.
If it doesn't go away in a week or two, if it's continuing, if, as Joel said, the patient has lost some weight, if there's bleeding, that's already a different kettle of fish. And that requires maybe a lot of conditions like gastroenteritis, viral gastroenteritis, food poisoning. Most of those things go away by themselves if you just wait them out. But if this has been going on for several weeks and there's weight loss and bleeding going on, then some bells go off and it requires further evaluation.
And Dr. Cohen, when does a radiologist get involved in this case? When do you get involved?
Well, I get involved when the gastroenterologist or the surgeon really asks me to get involved, and they're the ones who determine if they think, let's say, that there's a question of, let's say, inflammatory bowel disease. Then we discuss what's the best examination to do to make that initial diagnosis of inflammatory bowel disease. And at this point in time, we have really two basic examinations that we do, and they would be dealing with either CT scanning or with MR. And those are really the tests now, things like MR enterography or CT enterography. And that's how we start, but that's really based on the ideas that we get from the gastroenterologist or the surgeon. It's a question of obstruction, it's different tests, but it's really based on what the clinician asks. Our job is to help the clinician make his or her diagnosis.
So now, go ahead, Joe.
Peter, a lot of people, including the one that I just referred to you, this 30-year-old young man, are confused about the difference between IBS, which is inflammatory bowel symptoms, versus IBD. So how can you, this person knows nothing, they've had cramps, they've had weight loss, but they've also had some bleeding. How do you differentiate IBS from, let's say, IBD, whether it's Crohn's or ulcerative colitis?
So IBS is irritable bowel syndrome,
Right.
And IBD is inflammatory bowel disease.
Right.
And there's certainly more irritable bowel disease out there than inflammatory bowel disease.
Okay.
Irritable bowel syndrome is much more common than inflammatory bowel disease. But in this case, the things that would raise your worry is the fact that there's bleeding and weight loss. Bleeding and weight loss do not go with irritable bowel syndrome. And unfortunately, an awful lot of people are told that it's irritable bowel syndrome, especially young women. There is a bias out there to say, oh, you're just nervous. It's an irritable bowel syndrome. But
so what would be the first test that you do if the patient, as I said from the very first, has lost 10 pounds, has had intermittent diarrhea, and has occasional bleeding?
Well, I would say the sequence of events is you take a history, you do a physical, you do some blood tests to see what's going on, you make sure that there's blood in the stool, and then you might want to get a culture of the stool to find out if it's an infection. Right. There's an awful lot of infections out there.
So the
not
culture
just
comes
COVID.
back,
There's more to life than COVID.
You do all of that, and the culture comes back normal flora. There's no pathogens.
Good.
What is the next thing? And let's say they have a hemoglobin that shows that they're anemic. Let's say 9 grams or so, with the normal being somewhere between 10 to 12. So what would you then recommend? Would you send them to a radiologist? Would you do an endoscopy?
Well, I think that in a case like that, where there's red blood coming out from the bottom, then that's usually a lower problem. It's lower in the
Lower where?
gastrointestinal
Yep,
tract,
th-
like
these are
the
layman.
colon, the rectum,
Colon,
or the
large bowel.
sigmoid, or somewhere in the colon, which is the large intestine. And the best way to make that kind of a diagnosis is to look in with a light, and that's colonoscopy. Colonoscopy is looking into the lower colon, into the lower intestine with a light to see what's going on. You can tell where the bleeding is coming from, how high it goes, how active it is, and whether there's anything you can even do about it with a colonoscope to stop the bleeding. So you can get a tremendous amount of information, from that kind of a test.
So
And-
Dr. Rubin, sorry, and Dr. Cohen here, we've had, you've talked a lot about a number of sophisticated tests and also waiting for results back. This sounds like a pretty extensive process and lengthy process to get the real diagnosis. Those patients who are out in the country and not close to an academic hospital, do they need to seek out an IBD expert to get this diagnosis? Is that where patients are being diagnosed, or do primary care physicians, family doctors also diagnose IBD out in the country?
I think that primary care physicians and general practitioners certainly know about these diseases.
Mhm.
And they do have to, if they're well trained and thinking clearly, they certainly think about it, and they can do a lot to help to establish these diagnoses. So I don't think that every single person with this set of symptoms needs to be referred to an inflammatory bowel disease specialist right off the bat. I think that they should try to go as far as they can in making the diagnosis and treating it. And a lot of community physicians are very sophisticated, very up to date, and they know what to do. I think that we get to see the patients who are not responding to those kind of treatment.
So just let's say to move this along, that you see and you have the data in front of you that the primary care physician has done a stool culture and has looked for parasites, and there are none. But again, this patient is bleeding, is slightly anemic, has some cramps, and they've even taken some antidiarrheal medications, and they're not responding to that. So what is the first, and you talk to them and you don't find anything specific. It's not related to their diet. What is the first thing you do? You said if they're bleeding bright red,
Look, for
you do an endoscopy.
that kind of a patient, you need a colonoscopy first.
What are you looking for? What are you looking for?
I'll tell you what you're looking for. Besides inflammatory bowel disease, you're looking for cancer.
Right.
As you may know, there's been an uptick in cancer in young people, in people in their 30s. Chadwick Bosworth, Darryl Strawberry, to name two luminaries who are sort of poster boys for this. But there's a lot of colon cancer in young people, and it's being passed on. It's being either called nervous or hemorrhoids without anybody doing any investigations. So it could be cancer, it could be hemorrhoids, or it could be inflammatory bowel disease.
As a transplant recipient, now I'm mixing myself in here, but I also have a question from the audience from a fellow transplant recipient. Is IBD or IBS or cancer more common in transplant recipients?
Peter, you want to handle that?
I don't think that IBD is necessarily more common. It's certainly more complicated to treat them because they're already taking all sorts of other medications for their transplant. But you still need to work them up and see what's going on. The first thing with transplant patients is you want to make sure it's not some crazy infection,
right?
As you know, but obviously that's already been looked for by the community physician. And if they've done the most sophisticated kind of testing, you have to realize that stool testing even has become much more sophisticated in the last 5 or 10 years than it used to be. They can now test for many, many different possible causes of diarrhea and bloody diarrhea than we used to be able to. The whole PCR panel, but I think that's available to community physicians, everywhere.
So let's say you scope the patient and you're not sure just from the appearance. Let's even say, all right, well, let me stop there, that you're not sure if it's Crohn's or ulcerative colitis just by looking at the lining of the intestine, the mucosa. would you send that patient to Dr. Cohen or some radiologist at that point?
Well, sure, because you want to know the distribution of the disease, how much of the intestine is being affected by whatever this disease is. And a colonoscopy can only look at the bottom part of the intestine. And you want to know, certainly for Crohn's disease and for many other conditions that you may be thinking about, what's going on in the rest of the intestine. And Dr. Cohen and the tests that he does, the CT scans and the MRIs can certainly help us by telling us what's going on above where the colonoscope can reach. And
Just
that
for-
can be
What can you
crucial.
tell about the colon and the small bowel from either a CT enterography or a CT
Or-
barium enema or an MRI?
So basically nowadays, in a patient like that, if you had a question, we could do one of two tests, an MR enterography or a CT enterography or a CT scan. And the idea is to really look at the small bowel. The colon's already been looked at by the gastroenterologist, and maybe even the terminal ileum, the end of the ileum as it enters the colon. So I like to use either of those two tests. Very often now, especially in younger patients, we're using MR enterography, where we do these sophisticated images, including injecting of gadolinium, a contrast material, and we can look to see if there's activity in the small bowel. We can see the bowel pattern, and that's really one of the main reasons why we do it. In the initial diagnosis, we do that. We're asked to do that a lot.
You tell by the gadolinium if there's inflammation in either the small or the
I mean,
large bowel?
Not just gadolinium, it's also, there's certain other sequences that we use. It's called diffusion. It's where we can see if certain things have what's called restricted diffusion. Just to be very specific, we can tell that that's a sign of active inflammation, and that's
So-
been very, very helpful.
Just to be clear for our audience, what is the difference when it comes to diagnosis of ulcerative colitis and Crohn's?
Well, there's a lot of overlap between ulcerative colitis and Crohn's disease. As a rule of thumb, ulcerative colitis usually presents with bloody diarrhea and involves the lower part of the intestine. By definition, ulcerative colitis involves the colon. It's in the name. So it's only the large intestine that's involved with ulcerative colitis. Crohn's disease, while it can present with bloody diarrhea, most characteristically presents with diarrhea without blood. And Crohn's disease can involve any portion of the gastrointestinal tract from stem to stern. And so it can be hard to tell them apart sometimes, but usually we can tell the difference.
Mhm.
And the other thing that ought to be
People have asked,
mentioned, if I may, is that this differentiation between inflammatory bowel disease and irritable bowel syndrome, sometimes patients have both. And you need to recognize that. And they're not going to get better unless you address both in their treatment.
So some patients are so-called nervous about getting a colonoscopy. They don't want to take the prep. Do you use a prep generally for colonoscopy?
Sure.
Okay.
Yeah, you have.
What is that?
I mean, you
What kind
can't.
of, what kind of prep is that? And what has been your experience and the feedback from patients as to how difficult that day is, or whatever is prior to the colonoscopy? Because they're fearful, some of them.
I
Yeah.
can tell you it's very, I had to do it. I was very fearful. So I'd love to hear from the experts how you tell your patients not to be worried about it.
Well, we tell them that the examination is only as accurate as how clean the colon is when you get there. And it's not going to be fun. I mean, these are not medicines that you would order in a restaurant.
Right.
I mean, you just got to know these medicines are designed to give you big time diarrhea. Otherwise, we can't see what's going on. We're looking into a sewer. I mean, clean it out. We got to see what's going on. And it's not going to be a picnic. And we just tell them to be prepared for that and try to talk them through it and get it done. There is also involved, it will be some anesthesia. And people are sometimes very anxious about that as well. And we try to reassure them that with modern anesthesia, it's not bad at all. When it's over, you wake up and go to work.
So what are they, Peter, without getting into the actual chemicals that they take, they take an oral medication that gives them a bowel purge? And do
Yeah,
they
it's
do
either,
that
it's
the
either
day
pills
before,
or
2
liquid.
days?
It's either
Right.
pills or liquids, and
Right.
and there's a whole bunch of
When do
different.
they start that? If they have scheduled for colonoscopy at 8 o'clock on a Thursday morning, when do they start the pills or the liquid?
Wednesday afternoon.
And they're not going out that night, correct?
I don't recommend it.
Right. Okay. But
Do you recommend eating a little bit less already the days before, so there's less to clean out?
Oh, maybe I recommend going on a liquid diet the day before.
Yeah.
A liquid diet, maybe the day before, and then take the prep late in the day before, and then you come in the day of the examination without eating or drinking anything.
I want to ask a different kind of question now. So now it's a different patient who's having cramps, no bleeding, and significant weight loss, and some intermittent diarrhea. And let's just make it simple. You do a colonoscopy and you don't really find any significant disease in the colon, but you get into the terminal ileum and you see some inflammation in the terminal ileum. What do you do next? Do you send it to Dr. Cohen? What do you suspect is going on? What's causing the cramps and the distension?
Well, we ought to make sure that the audience knows what a terminal ileum is. That's the bottom of the small intestine. So you're saying when we've done a colonoscopy, we've gone all the way up to the top of the colon, and we've actually swung around into where the small intestine meets the large intestine, and that's called the terminal ileum. It's a terrible name, but that's what it is. And if you see inflammation in there, obviously you immediately think that there's some sort of small bowel disease, and Crohn's disease certainly prefers the site. The anatomic site that Crohn's disease prefers is the terminal ileum. So you'd certainly want to know what's going on up there. You would take some biopsies at the time of the colonoscopy and then refer the patient to Dr. Cohen to understand how much of the small bowel is involved with this process. And his tests are very useful.
Do people have to be fearful that your biopsy is going to cause hemorrhage or perforation?
No, because it's a tiny, tiny biopsy. It's smaller than a baby fingernail that we're taking, and it's very superficial, and it's done under direct vision, and there should be no problem, with that.
How many biopsies do you take from an area that you want to analyze? I mean, how accurate is it? Because
if you see something abnormal, then you don't need many biopsies,
right,
because it's going to be there. And we certainly to at least 2 or 3 biopsies, and sometimes 4, what's called 4 quadrant biopsies, north, south, east, and west, in order to sample that area.
So let's say the colon on your colonoscopy, I assume you're doing the colonoscopy as one of your first tests. Let's say you sort of the channel of the small intestine seems to be getting a little narrower as you get up maybe 6 inches or so. Do you refer that patient to Dr. Cohen so he can see what's going on?
Sure, because he's going to approach it from the other end. Right. He's going to give the patient something to drink, and he'll be able to approach it from above, and will be able to tell us what's going on down there.
So what can you see, Dr. Cohen?
I can be very helpful. I can be very helpful in looking at that small bowel. And if there's a question about an obstruction, the test that I like to do then is a CT scan. Because with a CT scan, I can really see the bowel very well and see if there's areas of obstruction. Sometimes there's more than one. I can see the length of obstruction. I can see if it looks like there's active disease or not. So I like to start off with, if there's a question of obstruction, something like that, with a CAT scan, a CT scan of the abdomen and pelvis, CT enterography. And that's very, very worthwhile. And that sees the whole small bowel very well.
How often do you see obstruction in the diagnosis as part of the diagnosis?
Of ulcerative colitis or Crohn's?
Well, it's much more common with Crohn's than with ulcerative colitis, for sure, because Crohn's involves the small intestine and can give you an obstruction. Ulcerative colitis rarely causes obstruction, and if it does, it's usually a very serious case. But certainly obstruction, small bowel obstruction, is Crohn's ever so much more often than anything else.
So let's say, I think we have to move along a little, right, Karin, for questions?
Yeah, we have about 5 minutes left.
5 minutes. So Peter, let's say you see ulcerations in the colon, you see no strictures, and you get into the terminal ileum, and the terminal ileum looks normal. Let's say you take some biopsies of the colon, and it comes back, the mucosa is inflamed, and you don't see anything specific for Crohn's. What is your first line of treatment? Do you recommend treatment for that patient?
Oh, sure. And now you're talking about all the drugs that are available to treat ulcerative colitis and Crohn's disease, which is enormous. And this is really,
We have a special seminar about coming up.
and hopefully there'll be a special, seminar on that. And the drugs, the medicines that are available to treat this are growing exponentially. And
What
every
is your
month,
first line of
new ones
treatment
come.
for
It
that
depends on
patient?
how sick the patient is.
They've
it
lost
really-
10 pounds and they're a little
It,
anemic.
it really does. It does. If it's mild to moderate, then you'll give them certain pills. Mesalamine is the lowest group of medicine. And then it goes all the way up to these very fancy medicines that you see on television for the real sick patients. And many require that, and they're wonderful medicines, but sometimes you don't need them. You don't have to necessarily drop a bomb on every patient who comes in.
So just to reassure a patient where you think the patient has ulcerative colitis, what can you tell them that the likelihood is that you're going to be able to treat it and cure them just by giving medications and to avoid having surgery? What percentage?
I think very high. I would say over 80%. I think that we can certainly calm them down and get them hopefully into at least clinical remission. And they're not certainly going to be referred to a surgeon right off the bat by any means.
And for Crohn's, better
Same thing.
treatment?
Same thing. They need to be, unless they're completely obstructed and they can't take a sip of water or something like that, then that's a different matter. But if it's a mild to moderate case of Crohn's, we have tremendous number of ways to treat this.
And just
so now you've treated. I'm sorry,
Go
Karen.
ahead,
So
Karen.
I just want to get into one more.
I just wanted to
issue.
understand the patient. If we think about the patient here again, we've heard about your patient over and over again, Joel, which is so great. This patient has lost weight and so on. What is the age range, the kind of the average age range of a person coming into your office with this kind of diagnosis?
Peter, why don't you answer?
They're usually it can begin with teenagers.
Mhm.
They're usually in their 20s and 30s when it starts, but there's an enormous age range. We see it in geriatric patients. We see it in patients in their 50s, 60s, and 70s. That's more unusual, but I would say that the majority of them are in their 20s, 30s, early 40s.
Yep.
So now the patient had ulcerative colitis and has responded very well to the medications. When do you tell them, do they have any risk factors for cancer or anything like that? Do you tell them, when do you tell them to come back? You treated them for a year, you treated them and you see them in 6 months. What do you tell them?
Well, the first question is, should they continue their medication once the bottle is empty? And the answer is yes, because these are diseases, these are chronic diseases. And even though we get it under control, it doesn't mean it's going to stay under control. So
this is an important point, really important point, I think.
Because
all of you,
this is the hurdle.
Yep.
Patients will say, oh, the bottle was empty, so I stopped.
Mm-hmm.
Well, what about the 6 refills that were ordered on that bottle? You have to continue to take it. There needs to be a dialogue. The most key thing for these patients with these chronic diseases is they need to have a doctor with whom they can talk and discuss what's going on, and then to make a mutual decision going forward of how much to do and how much not to do. And if they want to stop something, it should be a decision, a mutual decision about the pros and cons, the risk benefits of stopping or continuing a medication. And everybody's different, but these are chronic diseases. These diseases don't get better in a week.
And
or a month.
do you at the point of diagnosis, when you have this conversation with the patient, also involve other team members such as dietitians, mental health workers, others who may be helpful in this holistic approach of treating the patient?
Sure, everybody's different, and every person responds differently. So you offer them this whole sort of smorgasbord of things that they could do and see what resonates with each individual patient, and you offer them that. Unfortunately, a diet, for example, you'd love to believe the diet would cause or cure all these diseases. But unfortunately for ulcerative colitis and Crohn's disease, that does not seem to be the case. And people are disappointed to hear that. And
What
there's
kind of follow-up do they need, Peter? Because assuming you're saying that 80% of them will get well
Yeah.
with your medications. So now you have them come in for a follow-up. We're not going to get into the timing of the follow-up, but it's a year. They come back to you. What do you tell them? They're fine?
Depends how they're doing. If it ain't broke, we don't have to fix it. If they're fine, then say don't rock the boat, just keep doing what you're doing. And we don't have
surveillance colonoscopies.
Not right off the bat, not for at least 5 to 10 years, if they're doing well. There is a risk of cancer in chronic ulcerative colitis, but the key word there is chronic, and chronic is usually at least 8 to 10 years before the risk of cancer starts to go up in ulcerative colitis.
So is the risk of cancer more in ulcerative colitis patients than normal patients, same age, 50 years old? Yes.
Answer is yes.
So what about radiology during these remission periods? There's no need to do any kind of follow-up, obviously preventive or checking for other. So radiology really comes in when there is a need.
Problem.
Yeah, there's a problem.
Radiology is when there's a problem or some problem solving. If Peter has a question and he wants to know about parts of the small bowel or extent of disease, active or inactive, is it a stricture? Is it a stricture with active inflammation? Things like that. That's when radiology comes. Is there a fistula, fistulas, things like that? But if the person is doing okay, we don't want to see, let them stay away.
Yeah.
Although I would say that if we're judging the effectiveness of a treatment, we really want 3 things. We want the patient to feel well. We want the tests of blood tests and so forth to look well. And we want the tests that were abnormal at the beginning to also look well. So that we want the colonoscopy to have been improved. We want the small bowel series or the CAT scan to look improved. That's the way we judge the improvement or the effectiveness of the therapies that we're giving.
I'm just saying as an ongoing thing,
No, not necessarily.
We don't do surveillance.
No.
Right. But it's interesting you say that they may not need colonoscopy for 5-10 years if the treatment works.
With brand new disease, not necessarily.
Yeah, that's great.
But if they're feeling well, do you want to see, let's say, how the inflammation in the colon or the lower colon is doing? Is that one of the ways that you judge it?
I mean, we have to follow them. It depends on the patient and how they're doing and how bad things were at the beginning. But in terms of surveillance for cancer, you don't have to worry about that right off the bat. To see
what about someone who's had mild ulcerative colitis, they've responded to whatever medications, but they continue on the medications, and now it's 10 years that they've had ulcerative colitis.
Oh, they need to be looked at again. I mean, at that point, they need to be looked at again. We see how the colitis is doing, and biopsies are taken again to see whether it's just to the naked eye or how much of it is microscopic. And at that point, it certainly needs to be done again. No question.
And then, as you said, and we do need to close, but you spoke somewhat highly of the primary care general practitioners out in the country. Do you kind of work with them if during the surveillance, or are they totally autonomous during this process? Or
no, I think they need to be included. They're the ones that are close to the patient, geographically and emotionally to the patient. And I think that you try to involve them. You send them reports. You call them, they have your number, and sometimes even when the patient comes in, you call them right on the spot to make sure that, it's got to be.
So if your first line therapy is mesalamine, let's say, and they've responded, which is nice, right? Are there any side effects that are significant from giving a patient mesalamine?
Usually not. I mean, there are a few rare ones, but usually they're very well tolerated, and they're relatively inexpensive compared to the others choices. And so if they're on that and they're fine, you sort of leave them alone. Yeah, I do like to see them at least every 6 to 12 months just to make sure everything's okay. But you can leave them on for decades.
That's great. I think we have to conclude. Joel, any final comments?
I think this was excellent. I think we covered a lot of ground. And we can get into much more specifics once we finish the whole webinar series. We'll see what questions may have not been answered, but we have about 10 sessions, I believe. So we'll see what's going on.
Yeah, I really want to totally agree with you. This was great. And thank you so much for the great debate and the engagement here. What is nice to hear is that there is a team effort going on, and you know, doctors working together, really taking care of the patient, involving also other providers. And I think as patients with symptoms out there, thinking about the bloody diarrhea and weight loss as cardinal symptoms, maybe not pain as much as some people may think. It's really the diarrhea and the weight loss that would make you seek care, and it's going on for a while. Then don't hesitate to go and see your physician, who will then be able to refer you to a specialist. And you have some good names here, but there are others in the country as well. So thank you so much, Dr. Cohen, Dr. Rubin, and of course our leader, Dr. Bauer.
Thank you.
We will see you soon again.
Bye-bye. Thank you.
Thank you.
Bye.